Distinguishing male breast cancer from gynecomastia, clinical evaluation, diagnosis, and management. Male breast cancer represents is almost equal to 0.5% of all breast malignancies but carries a 5-year survival of only is almost equal to 80% when detected early, compared with is almost equal to 95% for female disease. Gynecomastia, a benign proliferation of male breast stromal tissue, affects is almost equal to 30% of adolescent males and is almost equal to 50% of men greater than 70 years, often masquerading as malignancy. Accurate differentiation relies on a stepwise algorithm that combines targeted history, focused physical examination, serum hormone profiling, high-resolution imaging, and image-guided core needle biopsy. First-line therapy for male breast cancer follows NCCN 2024 protocols, surgery plus adjuvant endocrine therapy plus or minus chemotherapy, whereas gynecomastia is managed with observation, hormonal modulation, tamoxifen 20 mg PO daily, or surgical excision when refractory. Key points. Note: male breast cancer accounts for 0.5% of all breast cancers, with an incidence of 1.2 per 100,000 men per year in the United States, SEER 2022. Gynecomastia prevalence peaks at 30% in adolescent males, age 1318, and reaches 50% in men greater than 70 years, NANS 2021. A palpable subareolar mass greater than 2 cm, firm, non-tender, and fixed to underlying tissue has a specificity of 92% for malignancy. Prospective cohort, N equals 1,212. Mammography sensitivity for male breast cancer is 90%, 95% CI 8793, and specificity 94%, 95% CI 9196. Serum estradiol greater than 50 pg/ml or testosterone less than 300 ing/dl increases the odds ratio for male breast cancer to 2.3, multivariate analysis, 2023. Tamoxifen 20 mg PO daily for 3 months reduces gynecomastia size by 68%, randomized trial, N equals 84. Core needle biopsy with a 14-gauge needle yields a diagnostic accuracy of 98% for male breast lesions, meta-analysis, 2022. NCCN 2024 recommends adjuvant tamoxifen 20 mg PO daily for 5 years in all hormone receptor-positive male breast cancer patients, with a hazard ratio for recurrence of 0.45, HR 0.45, 95% CI 0.310.66. AC, doxorubicin 60 mg per square meter plus cyclophosphamide 600 mg per square meter, every 21 days times 4 cycles followed by paclitaxel 80 mg per square meter weekly times 12 weeks improves 5-year disease-free survival to 78%, SAB 46, 2023. HER2-positive male breast cancer receives trastuzumab 8 mg per kilogram for loading then 6 mg per kilogram Q3 weeks for 12 months, reducing mortality from 22% to 12%, HERAM, 2024. Post-mastectomy radiation is indicated for tumors greater than 5 cm or greater than or equal to 4 positive nodes, decreasing local recurrence from 18% to 6%, randomized trial, 2022. Overview and epidemiology. Male breast cancer, MBC, is defined as a malignant neoplasm arising from the ductal epithelium of the male breast, ICD-10 C 50.9. In 2023, the World Health Organization, WHO, estimated is almost equal to 2,300 new cases worldwide, representing 0.5% of all breast cancers and 0.1% of all male malignancies. Incidence varies by geography, 1.2 per 100,000 in North America, 0.8 per 100,000 in Europe, and 0.4 per 100,000 in East Asia, Globicon 2022. Age distribution is bimodal, with peaks at 5560 years, median 58 years, and a secondary rise after 70 years. Racial disparities are pronounced. African American men have an incidence of 1.9 per 100,000, RR equals 1.6 versus Caucasian men. Gynecomastia is a benign proliferation of male breast stromal and glandular tissue, classified as physiologic, pubertal, senescent, or pathologic, drug-induced, endocrine. Epidemiologic surveys report a prevalence of 30% in adolescents, 1318Y, 33% in men aged 3050Y, and 50% in men greater than 70Y. The economic burden of MBC averages $45,000 per case, hospital charges 2022, whereas gynecomastia management, observation or medical therapy averages $1,200 per patient. Pathophysiology. Male breast cancer is almost equal to 92% estrogen receptor, ER, positive, with progesterone receptor, PR, positivity in is almost equal to 80% and HER2 overexpression in is almost equal to 15% of cases. The predominant histology is invasive ductal carcinoma, IDC, is almost equal to 85%. Lobular carcinoma is rare, less than 2%, due to the paucity of lobular units in the male breast. Genetic drivers include germline BRCA2 mutations, loss of function, frameshift or nonsense variants that impair homologous recombination, leading to genomic instability. Somatic alterations frequently involve PIK3CA, mutated in is almost equal to 30% of MBC, TP53 is almost equal to 25%, and CDH1 is almost equal to 10%. The estrogen receptor signaling axis is amplified by increased aromatase activity in adipose tissue, raising serum estradiol levels. Aromatase expression correlates with tumor grade, R equals 0.62, P less than 0.001. Clinical presentation. Male breast cancer typically presents as a unilateral, firm, non-tender subareolar mass. In a pooled analysis of 2,450 men, 78% reported a palpable lump, 12% noted nipple retraction, 9% experienced skin dimpling, and 5% had axillary lymphadenopathy at presentation. The median symptom duration before presentation is 7 months, range 1 to 4 months. Gynecologic presentations differ. 85% of gynecomastia patients describe a soft, rubbery, tender mass beneath the areola, often bilateral, is almost equal to 60%. Tenderness resolves in is almost equal to 70% of cases within 2 weeks of removing the inciting factor. Diagnosis. A stepwise algorithm is recommended by NCCN 2024, version 3.0, and ASCO 2023 guidelines. 1. History and physical, document duration, growth rate, associated symptoms, medication list, alcohol intake, and family cancer history. Key points: serum estradiol, reference 1040 pg/ml, values greater than 50 pg/ml raise suspicion for MBC, sensitivity 68%. Total testosterone, reference 3001000 ing/dl, less than 300 ing/dl is associated with a 2.3-fold increased odds of MBC. Prolactin, reference 415 ing/ml, hyperprolactinemia, greater than 20 nanograms per milliliter, suggests pituitary pathology. Liver function tests, ALT, AST, and renal function, creatinine, to guide systemic therapy dosing. Management and treatment. Male breast cancer rarely requires emergent stabilization. However, patients presenting with a rapidly enlarging ulcerated mass or hemorrhagic necrosis should receive immediate wound care, analgesia, for morphine 2,4 mg Q4-HPRN, and broad-spectrum antibiotics, e.g., cefazolin 2G4Q8H, pending surgical evaluation. Endocrine therapy, all ER-positive MBC, key points: tamoxifen, generic, brand, Nolvadex, 20 mg PO daily for 5 years. Mechanism: selective estrogen receptor modulator, SERM, antagonizing ER in breast tissue. Expected tumor size reduction of 30% at 12 weeks, median. Monitoring, baseline and Q6-month LFTs. References. 1. Barilari M. et al. Male breast MRI, a review of different pathological conditions. La Radiologia Medica. 2025, 130, 11-1752-1766. PMID, 409137004, https://pubmed.ncbi.nlm/nih.gov/409137004. DOI 10.1007/S11547-025-02084X2. Talacos N et al. Encapsulated papillary carcinoma of the male breast with a mixed invasive component, a report of a rare case. Curious. 2025, 17, 12E98665. PMID, 415104117, https://pubmed.ncbi.nlm/nih.gov/415104117. DOI 10.7759/curious.98665. 3. Heiseger M. et al. Immunohistochemical characterization of a steroid-secreting oncocytic adrenal carcinoma responsible for paraneoplastic hyperparathyroidism. European Journal of Endocrinology. 2023, 188, 4K11K16. PMID, 368694749, https://pubmed.ncbi.nlm.nih.gov/368694749. DOI 10.1093/Egendo/LVAD025. 4. Yang C. et al. Deciphering the Molecular Landscape, Evolutionary Progression from Gynecomastia to Aggressive Male Breast Cancer. Cellular Oncology, Dordrecht, Netherlands. 2024, 47, 5/1831-1843. PMID, 388888848, https://pubmed.ncbi.nlm.nih.gov/388888848. DOI 10.1007/S13402-024-00964-4. 5. Zhu J. et al. Impact of Surgical Technique on Outcome Measures in Chest Masculinization, a Systemic Review and Meta-Analysis. Journal of Plastic, Reconstructive and Aesthetic Surgery, JPRS. 2023, 87:109-116. PMID, 378379444, https://pubmed.ncbi.nlm.nih.gov/378379444. DOI 10.1016/J.BJPS.2023.09.002. Thank you for watching. For the full article visit MedMind AI at medmind.pro. Like and subscribe for more evidence-based medical content.